indicating the recording is starting. I want to thank everybody for joining us today for Dementia Friendly Tempe Presents. My name's Candace Hewitt, and I work for the City of Tempe as a Senior Social Services Coordinator. I'm responsible for the Dementia Friendly Tempe programs such as Memory Cafe and these monthly presentations. These presentations are scheduled on the second Wednesday of each month. Each presentation has a different topic related to caring for a loved one living with dementia. For more information on future presentations, please visit our website at www.tempe.gov/DFT. We'll provide this information again at the end of the presentation. Before we begin, I'd just like to go over some housekeeping. Like many of you, we've moved our connection to the community online, and we're experiencing a bit of a learning curve as we shift our in-person presentations to a virtual format. So please bear with us. Today's presentation is what caregivers need to know about medication. Our presenter today is pharmacist Laura McAview. If you move your cursor on your screen, a bar will appear with several icons, such as your video and microphone icons. During this presentation, to cut down on noise and distractions, all participants are going to be muted. If you look at your microphone icon on the bar in the middle of your screen, you'll see a slash through it, which indicates you're muted. To unmute yourself, just click on your microphone icon, and when you're finished speaking, click on the icon again to mute yourself. Our presenter will pause for questions throughout the presentation. If you want to ask a question, just click on the raised hand icon, indicating you have a question, and we'll call on you. Just remember to unmute yourself. Or if you prefer, you can type your question into the chat function by clicking on the word cloud icon on the same bar in the middle of your screen, and I'll read your question to the presenter for you. So with no further delays, I'll turn it over to Laura McAview to start the presentation. Laura, if you'd like to share your screen.
Will do. Just get my presentation up here. All right, does it look good?
We can't see it just yet.
No? Okay. Hold on one moment. Sorry, I got a little lost here. Okay, here's this. All right, how about now?
Yes.
Okay, wonderful. So thank you for that introduction, Candace. My name is Laura McAview, pharmacist at Honor Health, Thompson Peak. And I wanted to give this presentation to you all on what caregivers need to know about medications. So I've been a pharmacist for 4 years now, and last year I had the opportunity of being a dementia fellow in the Hospice of the Valley Dementia Fellowship in its second year, and I have so much information about how to care for people with dementia, and I just want to share some of the things I learned. So overall, we'll just go through a brief introduction about medications, polypharmacy, dementia, and then we'll dig into all the medication tips in medications for dementia, along with all of the kind of complications that could arise with them. So overall, the purpose of this presentation is to give you information, give you an idea of how we look at treatment, and make sure you have a conversation with the providers and your pharmacist. So every person is different. Everyone's going to need different treatment. I'm probably going to say you should avoid a medication that maybe your loved one is on, and that doesn't mean you just stop it. That means you should just have a conversation and see, is there a better option? Is there nothing else and this is the only thing we've got? And there'll be a risk-benefit kind of analysis and see what's the best thing for your loved one. So just make sure to not stop any medications on your own, especially because they can cause some issues and agitation and problems if they are stopped abruptly in certain situations. All right, so in general, as we get older, our bodies change too. So we have increased sensitivity to medications and feel their side effects more, and the way our bodies affect the medications change too. So we have slower metabolism of these medications, or our kidneys take longer to filter the medications out of our body. And also another big one is that our bodies have trouble controlling blood pressure as well. So we could be more at risk of having a fall or fainting if we get up too fast, for example, from laying down. And this is even more of a problem in patients with dementia because they can't really verbalize sometimes how it's affecting them, or not able to cognitively explain it the way a person without dementia would. So, as a caregiver, you guys are extremely important. You will be the eyes and the ears of the person and will usually catch things that maybe providers won't. So make sure to keep your eyes peeled for red flags like urinary incontinence, muscle weakness, tremor, loss of appetite, falls. Make sure to keep a nice log of all these, if any problems happen, or even if you're having a good day, just chart it on your log, and so that you can talk with your doctor after you go to the appointment. Of course, you're also watching for changes in mental status, excessive drowsiness, confusion, depression, sudden changes in speech and memory. And so you can use your judgment if it's a sudden change and something is not right, an acute agitation sometimes could mean that maybe there's something underlying going on. Maybe they need an emergency visit to the hospital to see if there's any underlying issue or infection of some sort. And really taking into account when was the timeline of these adverse effects. Was there a recent medication change? And that could be taking away a medication or increasing a dose, putting on a new medication. And don't forget about herbal supplements and vitamins. Those could count too and could cause side effects. And in general, polypharmacy is a term that we hear a lot, especially just in the elderly in general. It's when you have more than 5 medications and it increases your risk of falls, frailty, disability, and even death. So this is something we take seriously and we need to look at. So if there was a study that found 5 to 9 medications that a person takes increases the fall risks by 4 times. And if you take 10 or more, it increases the fall risk by 6-fold. So it's just another understanding of how important it is to review the medication list with your provider periodically and figure out, do I need these medications anymore? You know, from time to time, you might not need something, or you can try coming off of it with your provider's discretion, and maybe you won't need it anymore. So I'm not saying that you have to have less than 10 or 5, because that's just not the reality. Almost everybody has more than 5 medications, unfortunately. But I'm saying it is a good idea to make sure those are all still needed on the list from time to time. And probably one of your most important things that you could take from this presentation is to think all the time, can I treat this without medications? Because as you'll see, non-pharmacological, meaning without medications, those types of options are going to be preferred in people with dementia. So, of course, we have the different types of dementia, Alzheimer's being the most common with 60 to 80% of cases, and that's really where our medication therapy is. Vascular dementia, you'll see that's more decreasing your risk factors, so of hypertension, which is high blood pressure, high cholesterol, diabetes, and then you have Lewy body, Parkinson's, frontotemporal, and some rare diseases. And unfortunately, there's no cure yet to slow the progression of dementia and cognitive decline. So it would be a good idea to maybe look into clinical trials. If that's something you and your loved ones are interested in, this could help find the cure for dementia, because this is the way that we're able to figure out what's working, what's not, in which patient population. Other things we found that slow the progression is definitely exercise, improving the survival of brain cells, or eating a Mediterranean-type diet, so a lot of unprocessed foods, fruits, vegetables, lean meats, fish, and of course taking care of those risk factors that could add to dementia, which are high blood pressure, high cholesterol, obesity, smoking, depression. Making sure you just take care of yourself all the way around could help your brain health. All right, so let's get into these medications. So there are the three on the left, donepezil, which is Aricept brand name, galantamine or Razidine, and rivastigmine or Exelon. Those are our cholinesterase inhibitors. So that's just a long way of saying they increase the acetylcholine in our brains and kind of all over our bodies. That's one theory that researchers have found may be contributing to dementia. So they have these drugs that increase that acetylcholine. Those three work in mild to moderate Alzheimer's dementia. Rivastigmine is also FDA approved for Parkinson's dementia. And you can also use donepezil rivastigmine in moderate to severe. And then we have a new medication in the moderate to severe category called memantine, or Namenda. And it's also, as a combination product, memantine and donepezil as Namzaric. So memantine works in a different way than the cholinesterase inhibitors, the other ones. And memantine is called an NMDA antagonist, meaning it's trying to block the actions of glutamate, which is another neurotransmitter in the brain, with the theory that that glutamate is actually performing toxic pathways in the brain, causing dementia and causing those amyloid and tau proteins tangling and damaging the brain cells. So that's another option. None of these medications have been shown to be better than one or over the other, and even the combination product, memantine, donepezil, hasn't been shown to be better than either one of them alone. So do they work? That is the conundrum that everybody has to deal with. So they worked enough in the clinical trials for the trials to find a statistical difference between placebo and the medications. And those trials were sponsored by the manufacturer. So that's something to take into account. You know, we think of the bias that could have been involved in that. And when we do look at the benefit that they did find, they really only found like a 1-point benefit out of 30 on the MMSE mini mental state exam that checks for cognitive function, and that was in about 6 months to a year of the trial. So overall, it's known that people with dementia decline about 2 to 4 points a year on the mini mental state exam. So, that's like with these medications, you might decline 1 to 3 points a year instead of 2 to 4. That's the conundrum is that actually clinically important? It may not give you the benefit that you would hope for, and potentially you're just getting much more side effects in return. But 1 in 12 people do see minimal improvement, and 1 in 42 people have more of a larger improvement. But so that's why I would say it'd be okay to try these medications for 6 months to a year, see how your loved one's doing, discuss with the provider, and if there's really not that much improvement and the patient's having a lot of side effects, it may be more of a risk than a benefit. And we'll talk about the side effects coming up shortly. Memantine, the MMSE scale was no different than placebo, and there were a couple of other scales that they used. I won't dive deep into them, but it had to do with activities of daily living, and they also essentially had enough of a difference to become FDA approved, but doesn't seem like it's really a clinical difference in the patients. So I think it is important to have realistic expectations about these medications. We all want them to work. We want to find a cure and everything, but these medications won't improve cognition by any means. If anything, may stabilize or slow the dementia progression. And like I said, it would be good to try it for 6 months to a year, see if your loved one's getting benefit. But if their quality of life is suffering with the side effects, or there really isn't much benefit at all, you could consider coming off the medication, preferably coming off slowly, tapering off the dose, but that's not exactly required. And then definitely consider stopping in advanced disease, since you won't be able to tell much of a difference there usually. So what are these side effects that I keep talking about? Well, the cholinesterase inhibitors, they have a lot of gastrointestinal side effects, so diarrhea, nausea, vomiting, loss of appetite, weight loss, and, I kind of feel for these people who are taking these, but they're not able to verbalize their side effects or tell you them very well, and, and we're giving them these medications that we're hoping are working, but really could be just giving them issues and side effects. So things to remember is to stay hydrated, because diarrhea can really dehydrate you, and that could make them even more dizzy, and when you have not enough fluid in the body, it lowers your blood pressure. So getting up slowly after laying down or sitting down for a while, help them get up slowly to equilibrate their blood pressure. Another big side effect with these guys are a lower heart rate, and that low heart rate could cause fainting and dizziness. So if your loved one already has a low heart rate, like in the 50s, they usually try not to start these medications. So that's something to think about. Another thing is these cholinergic medications, I think of it as they make you more wet almost. As you get more diarrhea and you get more of a runny nose, and drooling could be a problem. And then lastly, trouble sleeping and vivid dreams or sometimes nightmares can be an issue as well. So I know donepezil, that one can cause a lot of nightmares. So even though a lot of the times it says to take it at bedtime, we change it to in the morning so that they don't have bad dreams or trouble sleeping. And you can do that with any of these medications if somebody's having trouble sleeping. Urinary incontinence, that's another one too that can occur with these medications. With memantine, since it works a little differently, it has more constipation, dizziness, headache, fatigue. Also has the trouble sleeping though, so you could take it in the morning. But it is a twice a day medication if you're looking at the twice a day formulation. So maybe taking it as soon as the person wakes up and 4 to 5 hours before bedtime might help with the trouble sleeping. Some other tips that I haven't mentioned yet are you could use the rivastigmine patch instead of the oral pills. The patch dramatically decreases the gastrointestinal effects, so that's good. But they're still there. They're still there. And lowering the doses may be something that you guys can do to decrease the side effects. And you should be aware that your provider will be trying to increase the dose. Mostly, that's what was done in the trials, is to titrate up to what they can handle to get the most benefit. But of course, if they're having side effects, then you do not want to keep going up on the dose. So this is something that comes up a lot because, and you don't have to fully grasp it, but with that acetylcholine increase, they call it cholinergic effect, and that's that diarrhea, that runny nose, urinary incontinence. Those types of reactions happen when there's more acetylcholine in the body with our cholinesterase inhibitors. The problem is sometimes for these reasons, like urinary incontinence, they'll put an anticholinergic medication on. So mechanistically, at least, it's completely discounting what the cholinergic medication is doing. We don't know exactly if that means there's less of a clinical benefit, but that would be the theory since it's blocking acetylcholine. And that causes the opposite, so constipation, dry mouth, confusion, urinary retention, dizziness, and falls. So we definitely want to avoid anticholinergic medications, not only in people with dementia, but really in the elderly in general. So those are some examples of commonly used ones are diphenhydramine or Benadryl over the counter, or oxybutynin, which is used for urinary incontinence. We see that one a lot where they add on a medication for a side effect of another medication, but maybe we just needed to get rid of or lower the dose of the first medication. Or a common antidepressant, paroxetine or Paxil. That one has a lot of anticholinergic effects and should be avoided. And we'll go more into that later. So what about other products or herbal supplements? I get a lot of questions about. Well, as a reminder, and your provider probably already checked to see if the person had low levels of vitamin D3, B12, B1. Because if those levels are low, you can give these vitamins, replace them, and it could help cognition. But overall, there's not enough great evidence to say that these supplements or any kind of herbal supplement works that well. Turmeric, that was seen in some small studies that it could help cognition, but better trials are definitely needed before we could really recommend them. And some things to know about turmeric is it could cause gastrointestinal diarrhea side effects as well, and potentially increase the risk of bleeding a little bit. So usually should be avoided if a person is already on a blood thinner. And the same goes for ginkgo biloba, that herbal supplement for improving memory, been used in Chinese medicine a long time, also increases the risk of bleeding while I'm on that. It did have improvements in some smaller studies, but nothing in the better studies, so still not recommended. Vitamin E was starting to show some positive results, but better trials are needed there as well. And there is a medical food called capryridine or Axana, and that's essentially trying to give the brain a different type of energy through fatty acids, but again, it was improvement in small studies, but not really in the better trials. Some other ones are omega-3 fatty acids. Those were associated with a lower risk of dementia, but not really in preventing or treating it. And cannabinoids, or CBD, that has been a hot topic nowadays. The CBD is the non-psychoactive part of the drug marijuana, but it can still have, what they found was some neuro protective effects. The THC, that's the more hallucinogenic or psychotropic portion, but that's being studied as well. So, and overall, when I was looking at the evidence, it was just conflicting. Some of them were saying that it doesn't actually have a clinical benefit, but at least it was safe because it didn't have a lot of side effects. And overall, there is emerging evidence that maybe more in the behavioral symptoms of anxiety and agitation, this could be something in the future, but right now, not enough to really say whether or not this is a good idea. But certainly talk to your doctors if you need to, or if you want to introduce anything like these into your regimen so that they can be aware, and it may be a potential interaction with your other medications, so that's why it's a good idea to talk to your providers first. Okay, so get into some more comorbidities that come along with dementia. So depression can be fairly common, it seems, in people with dementia. So definitely all of these things I will tell you to go non-pharmacological first. So what can you do to, spruce up life? You can put on music therapy daily, or do aromatherapy, massage, bring something familiar that the patient has seen, pictures. All of these things can help improve mood and prevent agitation and anxiety, and you're doing it all without medications that could potentially be harmful. Now, when the non-pharmacological options are just not working and it's really taking an effect on the quality of life of the person, we see some antidepressants being used, and for example, sertraline or Zoloft, escitalopram or Lexapro, citalopram, Celexa. Those are common ones that are used to fight depression and anxiety. And the last one, mirtazapine or Remeron, that one is a good one to use too. It's helpful, and if the person takes it at bedtime, it helps them sleep. And it also helps people gain weight, which may be needed in some of the thinner, more frail adults. So that's something to consider. You could kind of use the side effects as a benefit, depending on the person. And then, of course, trying to avoid some other antidepressants like paroxetine, because of those anticholinergic effects that we talked about that are also listed at the bottom of the slide. Because these can really cause confusion, falls, blurry vision, even delirium, which is like a sudden change in agitation and confusion. So that's something we want to try and avoid. Fluoxetine I placed on there since this one lasts in the body a long time. So, if the person's having some side effects, it's going to take a while for it to get out of the body. So that might be something to avoid until your other options are not working. Bupropion, that one is a little more stimulating than the other ones. So it can cause some anxiety in people. So if the other medications don't work, you could potentially try bupropion, but not a first-line option. It also increases seizure risk, so you don't want to use it first line if you don't have to, or definitely not use it in somebody with a seizure history. Amitriptyline or Elavil, that is an antidepressant, but it actually is more used for sleep. Regardless, though, it is very anticholinergic and should be avoided too. And then I put these two over-the-counter herbal supplements on here to avoid as well. So St. John's wort is used for depression, but it has many drug interactions. So that could be very dangerous. It could be increasing or decreasing the levels of other drugs in the body. So really a good thing to just stay away from in general. And this one and SAMe, it's called, they both work on serotonin in the brain to increase that and fight depression, but all of the rest of these medications do as well. So really, it should be avoided because too much serotonin in the brain can cause a rare but emergent situation of called serotonin syndrome, where the person has an acute sweating episode with wide pupils, agitation, and muscle problems. So just better to avoid. All right, anxiety, I can't stress enough. Aromatherapy, non-pharmacological therapy, meditation, exercise to try and kind of help the person without using medications. That'll be your best bet of actually getting some improvement. The buspirone, that's another anti-anxiety pill that could be used that works on serotonin as well in the brain. You could use the antidepressants. As a reminder, both the antidepressants and buspirone, they take like 3 to 6 weeks to work. So sometimes people can start getting a benefit at like 2 weeks, but that's something to consider, that it's just going to take a little bit of time with those to get benefits in depression and anxiety. And sometimes they even use gabapentin or Neurontin. You'll find it as an anti-seizure med or an anti-nerve pain med, but it can also have effects on the mood and some calming effects there. Now, does anybody have any questions so far? Okay. So some of the medications that might make a pharmacist cringe when they see these on an elderly person's profile, especially an elderly person with dementia, are these benzodiazepines, they call them. So it's like lorazepam or Ativan, alprazolam or Xanax, clonazepam or Klonopin. And these work in the brain kind of on the same receptors as alcohol, actually. And they can, while they work immediately for anxiety, they also cause a lot of problems with confusion, delirium, falls, and even worsening depression. And they also even have an addictive type effect. So really, if you could avoid these medications at all costs, that would be fantastic. But I know there's certain acute situations where, especially being in the hospital, in the population that I see, they still give a very, very low dose sometimes if they've tried everything else and it's not working to calm the person down. The more behavioral symptoms that are associated with dementia, and these symptoms can kind of range from mild to severe. So it could be like the wandering, repetitive questioning, all the way up to severe, more agitated, aggressive, changes in personality and symptoms. What you want to think of first is what could be causing these changes in the behavior. So could it be as simple as the person's hungry or thirsty, cold? Are they constipated? really analyzing what could it be before going to, a medication to like stop their aggression, calm them down, when in reality maybe they just need something else. Another thing is, are they understimulated? Have they just been sitting there? Do they need something to do? Can you give them a picture book or, a stuffed animal or activity or folding socks? Something like that that could help them kind of stay busy and be happy instead of get agitated. Or their environment could actually be overstimulating them. Are there too many people talking? Do you need to go to a different room, turn off the TV, maybe make sure there's no harsh lighting, things like that. Those are the kind of options that you want to make sure are out of the way first. And then definitely taking a patient-centered approach, seeing what does this person like. So if John was a fisherman back in the day, maybe you can bring in pictures of him fishing and maybe even pretend with a stick that he's going fishing, fun things like that. You could have a lot of fun with the activities and potentially have, help the behavior and not have to use a medication. But what happens when maybe something is needed? Well, antidepressants do work for some mild symptoms sometimes, not all the time, but that's something to consider. And there has been talk that the medications for dementia, like the cholinesterase inhibitors or memantine, may help, but when there was a trial where it looked like that was a good trial, it didn't really show any improvement. So that's that. But in general, when safety becomes an issue for the person, if they're harming themselves or others, or everything else has been tried without success and they're very agitated, some antipsychotic medications could be used, but extremely, extremely last line. And some things to know is there's symptoms that rarely even respond to medications, like wandering or hoarding, apathy, which is losing interest in everything, repetitive questioning or withdrawing. So if they rarely respond to medications anyway, might as well just try to optimize the non-pharmacological ones. So let's see what's next. So yeah, in general, just to summarize, if you're going to go for a medication, think, is the behavior dangerous, damaging to social interactions, harmful to the person or those around him or her, and did the behavior not respond to non-pharmacological therapy? Well, then maybe you do need a medication. Or does the person need some emergency treatment? Like I said before, maybe there's an underlying problem, an issue, an infection, those types of things. So when we are looking at these antipsychotic medications, one big thing to know is that they have a black box warning, meaning just a very large warning that they can increase the risk of stroke and cardiac death even. And I believe it was 1 in every 100 patients treated could potentially die, based on the statistics of the trial. Granted, these trials were done in very ill patients, very advanced disease, but it's still something we don't take lightly, and that's why we try to use antipsychotics as least as possible, or at the very end when maybe their quality of life is poor because of this agitation, and maybe they need an antipsychotic. So the two at the top, olanzapine, or Zyprexa, or risperidone, also known as Risperdal, probably have the best evidence in treating agitation and aggression type symptoms. Quetiapine, that one works well, especially maybe in more of a Parkinson's or frontotemporal dementia, because those types of dementias can have more muscle rigidity and muscle issues. and quetiapine is the one that has the least effect on muscle rigidity. So we definitely want to avoid one of the older antipsychotics like haloperidol or Haldol in patients with Parkinson's or frontotemporal dementia because of the huge extrapyramidal symptoms, they call them, basically effects on the muscles and the muscle movements. Abilify or aripiprazole is just another one that could work if the other ones aren't working well. So their side effects do include sedation, which may be preferable if the patient can't sleep, and you can they could be taken at night. But over-sedation isn't good as well. So something to think about. Low blood pressure can happen as well from when they are laying down to sitting to standing. That's also known as orthostatic hypotension. These antipsychotics, not really as much Haldol, but they can cause weight gain, high cholesterol, high blood sugar, and have these like metabolic effects. So that's something just to take into consideration that the physician will need to monitor. And like I said before, they could have that tremor, involuntary muscle movement, or muscle stiffness more with Haldol than some of the other ones. But it's still possible with olanzapine and risperidol. In general, we try to use these medications at the lowest dose possible for the shortest amount of time possible that we can. Another one that has shown some improvement in agitation and aggression is actually an anticonvulsant, meaning anti-seizure med, called valproic acid or Depakote. So this could help. Be sure to watch for side effects of rash, bleeding risk, dizziness, confusion, less commonly liver problems. Your provider might need to take some levels of the drug in the blood to make sure it's at the right level. So again, these benzodiazepines are here because they can be used sometimes in agitation when there is no other option, but really trying to avoid these at all costs if possible due to falls, fractures, confusion, delirium, increased risk of death too. So something to consider. But I will say it really is just that risk versus benefit conversation with the provider. So don't be scared if your loved one is on any of these medications right now. You know, it's really a case-by-case basis, but it's never a bad thing to ask the provider, you know, is this still the right thing to do for this person? Like I said, apathy, that losing interest in activities, it doesn't respond much with medications. It really works better if you use activities by what the person liked in the past to get them interested again, you know. If medications are needed, the cholinesterase inhibitors might help. They've even done a little low-dose methylphenidate, which is a stimulant close to Adderall, or modafinil, also a stimulant during the day, might help them kind of be more interested in the activities of the day. Trouble sleeping. So this can be a big one. I will say sleep hygiene is the number one thing to do. And even if they do start medications, it's still good to continue on with your sleep hygiene, and maybe you can use a lower dose of the medication. But in general, you want to try and keep the lights on and the shades open during the day. Keep them active, getting walks and exercise. And then at night, you can turn off the shades, close them. Make sure there's night lights in your home to not have any falls at night. Reduce the risk of disorientation if they wake up in the middle of the night. This actually top bullet point is super important because it helps the person with their circadian rhythm. So it's our body's natural response to daytime versus nighttime, and how it perceives the day, and melatonin release at night. That's one of the hormones in the body that it signals it's time to sleep. So that's super important, and that can get off when people get older, but especially in people with dementia. Some other things is to minimize noise and electronics from 10 p.m. to 6 a.m., use earplugs or eye masks, making sure to not have caffeine, nicotine, or alcohol, probably ever, but definitely before bed, and using bedtime rituals to signal the end of the day can be very helpful. Now, if these things are being done and it's still not really working and the person's still having trouble sleeping, you could give some melatonin. So it is an herbal supplement over the counter, mimicking our body's natural release of melatonin, and you can give that 30 minutes before bedtime to help the body understand it's time for bed, and that is one of the safer medications. Sometimes it takes a few days or so to get going and really work, so make sure to give it a few days of a shot. Another one is called trazodone. It's actually an antidepressant, but it caused too much sedation in patients at the doses needed to be an antidepressant. So really, we now use it for its side effect of sleep at low doses. And that one seems to be more desirable in the elderly, but can still have some side effects of over sedation during the day. So making sure to get the right dose with the provider there. Another one's called Ramelteon or Rosaran. That's just a more specific melatonin prescribed drug. I would guess that it's expensive, but I'm not sure. Probably a lot of these can be. And then mirtazapine, that one we talked about earlier, antidepressant, can be very helpful for sleep. So the issue is that over the counter, there are some sleep aids that are so readily available, but are actually very detrimental to people with dementia. So that diphenhydramine or Benadryl, doxylamine or Unisom, chlorpheniramine, chlorphen, and those are not the only brand names. There's so many, even Tylenol PM, anything with PM in it probably has one of those 3 antihistamines in them. So, and those are very anticholinergic, meaning they have those side effects of dry mouth, constipation, confusion, blurred vision, and falls. So, and urinary retention. So, kind of retaining that urine in there, not being able to urinate well. So those should really be avoided. Other ones are like amitriptyline we talked about earlier, same side effects. Hydroxyzine, that's one. Vistaril or Atarax, used for itching sometimes too, but really also has the same side effects. Temazepam is a benzodiazepine too. So that one, if you can avoid, it would also be good. I guess if you were to use a benzodiazepine for sleep, I would pick that one versus the others. Let's see, the next ones are called Z-drugs. This is Zolpidem. Oh, I put Zolpidem as a brand name, but it's Ambien, Zaloplan or Sonata, and Ezopiclone or Lunesta. So those are the benzodiazepine-like medications. They're not benzodiazepines, but they also cause a lot of over-sedation and confusion, and sometimes like sleepwalking and other loopiness type side effects. So overall, try to avoid as much as you can in patients with dementia. And lastly, antipsychotics. Of course, we want to avoid those, but if you are going to use them, at least you could take it at night and get the benefit of helping sleep. Pain is another big one and a tricky one. So definitely want to make sure you assess for pain, because that could be one of the reasons why the person's having agitation and issues. So if you do find that they might have pain, trying non-pharmacological therapy, stretching, heating pad or ice pack, physical therapy may help. Remembering that you have like the topical agents, so Bengay or those types of creams with menthol and camphor in them. They don't get absorbed as much in the body, so topical is preferred. Lidocaine patch can be very helpful. Just making sure to keep that on for 12 hours and off for 12 hours in a 24-hour period. And those lidocaine patches are over the counter as well. I think their brand name is Salon Palm. Tylenol or acetaminophen, that one is definitely our friend. That can work for pain. And you can take it up to 1,000 milligrams 4 times a day. A lot of people don't want to push that dose because they're afraid of liver problems. And I mean, if you're taking it 4 times a day for years, and maybe then we have a problem, potentially overworking the liver. But I would definitely not be afraid to take this 3 times a day for a while, and kind of staying a little bit under that max dose, but at least taking 3,000 milligrams a day if the person's in pain and not controlled with non-pharmacological and topicals. Another one is gabapentin. That can be used for nerve pain, like I talked about earlier, and can be sedating too, so just making sure to use it at night, at least at the beginning, but it can be used during the day as well. So with pain meds, trying to avoid the over-the-counter NSAID products, the non-steroidal anti-inflammatory drugs, like ibuprofen, which is Advil or Motrin, or naproxen, which is Aleve, or extra aspirin. Your doctor might have the person on a low-dose aspirin, 81 milligrams, thinning the blood, preventing heart attacks and strokes, but in general, you don't want to take anything extra aspirin or anything, because they do have a blood-thinning effect, and they can cause stomach ulcers that could bleed, and they increase blood pressure and hold water in, and affect the kidneys. So in general, trying to avoid them would be preferred. If the person does need to take them, taking them with food and a full glass of water would be great. Opioid medications should be avoided, of course. They are medications like morphine, oxycodone, hydrocodone, tramadol, brand names like Percocet, Vicodin, Norco, Ultram. And these medications also cause confusion, sedation, constipation, falls. Overall, and tramadol can actually a little bit interact with some antidepressants because it works on serotonin a little bit too, so it might cause some confusion. In general, because we don't have that many pain options, like, in a way, they sometimes use a low-dose oxycodone if necessary, if the person's in severe pain, because as much as we don't want to use opioids, we also don't want the person to be in pain at all. That's a delicate balance there. Because a person could get agitated and get up and fall because they were in pain, or they could be having a drug side effect and get up and fall from the opioid. So that's a tough one. Muscle relaxants like cyclobenzaprine or Flexeril or metaxalone, those should try to be avoided because they can also cause a lot of sedation and sometimes that confusion. What about allergies and itching? Just making sure to think about the topical kind of things like a saline nasal spray. I also have nasal sprays on there like fluticasone, mometasone, xylazine. Those are nice because they don't really get absorbed into the bloodstream much. They just stay localized where the person's having issues with allergies or itching. Other antihistamines over the counter like cetirizine or Zyrtec, loratadine or Claritin or Allegro, which is fexofenadine, those can be better. They have less anticholinergic effects, if at all, and they are non-sedating, so they can be a little bit better in people with allergies or itching in general. And then, again, with some more topical agents, they do have menthol and camphor creams, calamine lotion, oatmeal baths, if that's something, although this was just kind of an extra slide. It's not really something that goes along with dementia necessarily, but I just wanted to throw in some of these as well. And avoiding, again, that diphenhydramine, that Benadryl, unless it's a severe reaction, of course, not being able to breathe or the rash is spreading rapidly or something, might do a low dose 25 milligram for a rash, but maybe, 25 to 50 milligram for an allergic reaction bigger than that. So again, that doxylamine is there, or chlorpheniramine, or hydroxyzine. Nausea I wanted to throw in there as well, which may be more caused by potentially some of the medications. So avoiding what's causing the nausea and maybe even lowering a dose or something of a medication might help if that's what's causing it. Otherwise, you might want to try some ginger over the counter or eating it too. Being aware that it does thin the blood, so making sure to not take it with other blood thinning medications like Coumadin or Eliquis, Xarelto, those types. And another one could be Zofran or ondansetron. We do use that one in the hospital quite a bit. It's still good to talk to your provider about it because we just want to make sure you don't have any heart problems before going on that. And we try to avoid some of these types of medications: promethazine, meclizine, metoclopramide, and prochlorperazine. The top two mostly because they have those side effects of anticholinergic, confusion, dry mouth, constipation, blurred vision. And the last two is because they can have effects on muscle stiffness and muscle rigidity. Of course, just to end, to make sure to not stop or start any medications without talking to your provider and the pharmacist there. They can help give you good information, and your provider knows you the best and then gets all the information from all sources, and they can really help make sure that you're safe and you're getting the best treatment. The pharmacist does have a keen eye for these medications, so definitely should bring your medication list to your pharmacy, to your pharmacist, and just say, hey, what are some red flags that you see that I need to talk to my provider about? And that might just prompt the provider and give them a reminder that, you know what, now that you're older, it's not a good idea to be on this medication. Let's switch you to something else. Keeping a current medication list for your loved one is extremely important because it makes a huge difference in how we take care of the person, especially in the hospital here. Use pillboxes, alarms, calendars to help remember medications. Keep a logbook of information to see, maybe you'll be able to find a pattern of what is causing some of the side effects and find which medication it might be if it is a medication. And using the same pharmacy if possible is preferable because then the pharmacist can see everything you're on and catch interactions and issues, whereas if another medication was at another pharmacy, they might not be in their system. All right, and of course, just some resources. They do have, the caregiver.org has a nice guide on medications as well, and Alzheimer's Association always has good information in my references. And I'd like to open the floor for any questions.
Laura, great presentation today, and wow, so much information. Kind of one of my takeaways is just all these these drugs have very serious side effects. So how does one really weigh the benefit of taking any of these medications when we're seeing a doctor for, the care of our loved one? It seems kind of overwhelming.
Yeah, yeah, it can be overwhelming, especially definitely, yeah, just talking about them, because the trouble is some people have the side effects, not all people too. That's another thing. So, but I think just keeping them in mind, and, just making sure to have that open conversation with the provider and say, hey, I'm worried about these side effects. Is there something that's better for this person? And that'll cause them to think, dig some more, and you can dig more in the non-pharmacological options. But I think it really just comes down to that person and how they're doing. If you've tried all of these things and this person still just seems miserable, and it's kind of affecting all the interactions that are with that person, it might be better. The benefit of the treatment outweighs the risks of the side effects. Yeah, it is a difficult thing to take on, but I wouldn't be too overwhelmed by the side effects. I think just having that open conversation and talking to pharmacist and provider and come up with a good plan.
Another question I have is, when is it time to talk to the doctor about stopping these Alzheimer's drugs that you're not sure that they're beneficial, as well as is there a point in time when other drugs should be stopped, for example, cholesterol medications? Any kind of thoughts and comments on that?
Yeah, that's a good question. The Alzheimer's medications, in general, in the trials, they were only studied for half a year to a year. Maybe one of them was in 2 years, but it seems like if they get benefit, you can continue them. We don't really have great evidence, but that's what physicians do. And if it's helping the person, and it seems like the caregiver says it's helping, then it is okay to continue as long as they're not having crazy side effects from it. I would say in advanced disease is when you would want to just say, hey, let's taper this off, and then you'll know for sure they're not having any side effects, especially because you're not going to get that much benefit. Or another time is if the person's been on this therapy for over a year and it's not doing anything, and the poor person is just having diarrhea and is not eating well because they're nauseous. I think it's a good a time as any. Like, you gave the medication a shot, and let's just taper it off. And yeah, with those medications for high cholesterol, diabetes even sometimes, and usually it's more in like moderate to severe disease. Those medications are possibly going to start having more risks and side effects and issues, interactions than they're worth, because some of them are to keep the person living for longer, like 10 years longer, or something in the future where maybe their prognosis isn't that long, unfortunately. So, yeah, I think it's going to be in that severe disease where taking off some of these medications is okay, and keeping them comfortable and happy and pain-free is going to be more of your goal than having them live longer.
Thank you.
Yeah.
Are there any other questions for Laura?
So I'm going to add,
Oh,
go ahead.
Jan. Jan, did you have a question?
So I was going to say, Lori, we've talked a lot about the drugs or medications that can be used for people who are living with dementia, but any comments relative to care partners? Particularly, we know this has been a really, really rough patch with greater depression and anxiety just due to all the concerns and more isolation. Any kind of general comments you might make to caregivers as they even meet with their doctors to talk about their own well-being, not necessarily asking for a drug, but wondering if maybe they need a medication during stressful times like these?
Yeah, absolutely. And that's an extremely good point. In fact, I meant to put in a slide on making sure all the caregivers still take care of themselves. And I know it can be extremely difficult and hard to take care of someone who's, and when their personality is changing and things of that nature as well, not to mention in a pandemic. But I think just some things you can do, going back to meditation and just things that make you happy. If you need to take a moment and have some time to yourself, make sure you still socialize. You can do the 6 feet apart with masks, but socialization just releases so much endorphins. Certainly, if you're having any issues at all, just have a conversation with the provider and talk about your issues. They might say something about meeting with a behavioral therapist, and therapy helps so much in so many ways just to kind of get information out there. That's why socialization can help as well. But talking to the therapist, there's absolutely nothing wrong with that, and in fact it's extremely helpful. And then if you need a medication for a short period of time too, absolutely. You don't have to be on these medications forever. There's a lot of medications that actually, I talk about side effects a lot, but in reality, these SSRIs, these antidepressants, are very well tolerated, especially the newer ones like escitalopram, which is Lexapro, or citalopram Celexa. So, especially in younger, people. So in reality, don't be afraid of talking to the provider, and whether it has a medication or not, do what's best for you, what you want to try, and it's okay to get help. Yeah.
Any other questions? Well, thank you, Laura, for a great presentation. And thanks to everyone who joined us today. I hope you have a great rest of your day. And I will be sending out, if you provided your email during registration, I'll be sending out some additional resource information that Laura provided. And I'll be sending it out this week. So thank you for joining us.
Thanks, everyone.
Thank you.